Good afternoon, everyone. So I will be basically talking regarding the what all things you need to keep in mind while for the preoperative evaluation in a patient we are planning for multifocal and EDOF IOLs. So, as you all know, cataract surgery has evolved from evolved to refractive cataract surgery with patient. There is a shift in goal from mere visual restoration to the spectacle independence and emmetropia. And with the help of advanced IOLs, we were able to do it to an extent actually. So, why this multifocal IOL success starts before surgery? Because first thing is the pre-operative evaluation, patient selection is very critical, and even with advanced diagnostics, the predicting post-operative satisfaction remain complex. So we need to keep in mind all these aspects. What are the patient expectations? We need to be very all the measurements and assessments should be spot on, and also we need to properly counsel the patient regarding the adaptation. So main and important thing is the history. That is, we need to have adequate chair time with the patient before planning or before going for the premium IOLs. We need to assess what are the patient, what are the visual goals, and what is the profession of the patient, what type of personality the patient is. We need to actually assess the person as a whole, not just looking into the eyes, but we need to assess the person as a whole. And we need to give realistic counseling. We should not tell like, if you put this lens, you will get everything near, in intermediate, distant vision, everything. We need to counsel the patient accordingly. And lastly, identify the poor candidates, and we need to rule them out. So we need to counsel the patient regarding the neuro adaptation, which is very important and critical in patients planning for multifocal IOLs. And studies have shown that bilateral implantation within short time frame often improves the adaptation success. These are the side effects most commonly which can be there post-operatively in patients with multifocal. So next step is detecting and addressing the pre-existing ocular surface conditions. So this is one of the most important thing which we need to keep in mind, because untreated OSD can lead to poor visual quality and refractive surprises, compromising on the surgical outcome. So if you put an IOL, multifocal IOL in a patient with ocular surface disease, it would be like rebuilding the engine but driving with a muddy windshield. So always evaluate for it and rule out severe dry eye disease, and if it is there, better to not to go with multifocal IOL. So proper preoperative screening and aggressive treatment for optimizing the ocular health and patient education is of prior importance. So tear film instability and hyperosmolarity can result in variable K readings leading to refractive surprises, which can be catastrophic in patients of multifocal IOL. And visual fluctuations caused by dry eye disease create perception that they attribute everything to the IOL. So you need to counsel them properly, and we need to treat the dry eye disease and the ocular surface condition before. And this is just to highlight the point that perioperative cyclosporin therapy actually helps in better visual outcome, as well as the better contrast sensitivity and all will be better. So next step is accurate biometry and IOL power calculation. As you all know, optical biometry is one of the main main thing which you need to do for a patient planning for IOL, for multifocal IOL. So there are wide variety of optical biometers available. The current or latest being the SWEPSO. So if you have access to it, very well and good. We will all, this is the two main SWEPSO OCT based biometry, being one being Argos and one being IOL Master 700. So all the measurements will be very accurate, and so in order to prevent any post-operative surprises. And astigmatism, it's a silent vision disturber, because we need to if the patient is having pre-op astigmatism, even low values of 0.5 diopter need to be corrected with either with toric IOLs or with LRIs. You need to correct it, otherwise you will end up in trouble, patient being dissatisfied in spite of putting the multifocal IOL. It may not serve the purpose. So all these latest biometers and devices measure both the anterior and posterior corneal astigmatism, leading to very less errors. IOL power calculation formula is very like important in terms we need to use later generation formula like Virgin formula, which incorporates multiple variables and to predict the ELP. And apart from that, we have newer ray tracing aberrometry formulae, AI based formula and is also available. Coming to the aspect of post-refractive surgery, these patients will be demanding for multifocal IOL because they actually want spectacle independent. That is why they did refractive surgery. So we have a misconception in mind that they are always unsuitable for multifocal IOL. But I would say they are a wide variety of diverse group, and some of them actually can achieve excellent outcomes with the multifocal IOL. We need to document, however, minimal corneal higher order aberration, regular corneal surface, and absence of irregular corneal astigmatism before implanting multifocal IOL, but always better to avoid in post-RK patients. And with latest refractive surgery machines, they leave the corneas with lesser aberrations post-operatively. And in case of myopic LASIK, being the main chunk of refractive surgery patients, they actually have positive spherical aberration in the cornea post-refractive surgery. So better to go for aspheric or negative aspheric IOLs, multifocal IOLs, which can actually compensate for this. And Barrett's-Rouquet formula is one of the good formula, and this is another ASCRS online calculator which has simplified the life of all surgeons. It is just free of cost. You can just multiple modules being available, and they give an minimum, maximum, and average IOL power at the end. It is just, I'll show the screenshot. This is how it looks like. You can just enter the basic details. If you have the pre-refractive surgery keratometry and other details, you can enter that also. And finally, they will give something like this. They will use multiple IOL power calculation formula to give average IOL power, minimum and maximum power. So we can choose the IOL power for the patient accordingly. Angle kappa is something which we usually look for the before planning multifocal IOL. Multiple studies have shown that, and they have showed that if it is more than 0.5 or 0.8, better to avoid the multifocal IOL. But there is another school of thought showing that recently that the clinical utility of angle kappa as a rigid exclusion criteria for multifocal IOL is not correct actually. They say that and studies have found that patient satisfaction studies have failed to find a strong and consistent correlation with the between angle kappa magnitude and the reported patient dissatisfaction or photic phenomena. So just excluding that only on the basis of angle kappa is also like not very correct. That's their thought process. So, and we need to look for the pupil. It should be perfectly round and well centered for this multifocal IOL perfect outcomes actually. So studies have shown that if the photopic pupil should be less than 3.5 and mesopic less than 5 mm for the better results. As you all know, capsular back stability is one of the most important thing. A perfectly centered multifocal IOL centration happens only in a stable capsular back. Any instability, let it be like pseudo exfoliation, PCTS, anything can lead to decentration and loss of multifocal IOL outcome. Higher order aberration is something which you need to look into, especially post-refractive surgeries and all. The patients can have higher order aberration, so we need to evaluate. This is a machine, iTrace machine, which actually look into it. There is no real guidelines for the cutoff, but review suggests, literature reviews recommends less than 0.3 micrometer. Actually, you can proceed with the multifocal IOL. And always, it is like very basic thing which you need to evaluate the OCT macula, the optic head abnormalities, everything you need to look into actually. And last point based on that is the role of ASOCT, even though limited in special circumstances in posterior polar cataracts or intumescent cataract, it actually can help in planning. Just going through the last 2 to 3 case examples. This was a 40-year-old patient who was an IT professional, complained of glare and difficulty in night driving. On examination, he was having posterior subcapsular cataract. Even though he was having BCV of N66 and N6 with glasses, he was very much having these glare issues and other problems. So we did biometry and we implanted VVT IOL in left eye. But later on, the patient was not happy because when we looked into it, he was having a pre-op cylinder of 0.79. So in multifocal IOL, if we don't correct it, as I told earlier, it can lead to, even if we do everything right, the patient may not be satisfied. So always keep in mind, if there is even the small amount of astigmatism, you need to correct it. Second case example, it was a case of a housewife who decided for spectacle independence. She was having near mature cataract in both eyes, but her personality was sort of very much like, like everything, it was a sort of perfectionist like thing. So we actually, when we looked into, she was having, went down to biometric readings, she was having little like calculation, angle kappa calculation was on the higher side. Even though it's not, we cannot take on one single this thing about and as a strict contraindication. But since considering the patient personality and all, we avoided the multifocal and we implanted with the monofocal plus IOL, and eventually she did well. She was having 6.6 N8 unaided. Last case is a case of post-LASIK patient who wished for the spectacle independence with minimal cataract. Actually, she was having best vision BCV of 6/6 both eyes. This was a topograph showing minimal changes, and when we looked into higher order aberration also, it was on the lower side. So we implanted both eye panoptics, and eventually she did well. She was having unaided 6.6 N6 vision. Just wanted to highlighting the fact that not all cases of post-refractive surgery we need to avoid multifocal. This was that patient's ASOCT showing the corneal interface, that flap cut in the section. So that's all. Thank you. Next, I would like to.
Yeah, thank you, Dr. NAVAROSH. I think I request Jayaraman to just go to the podium for his presentation. Before that, a couple of discussion I want to know. See, one very important the point you had mentioned about in your presentation about the pupil size. Of course, in the pupil size, as you said, that less than 3.5 mm in mesophic and more than around up to less than 5 mm in the scotopic pupil. That is also very, very important. That's okay. 3G. Yeah, that is. But the one important point I just want to highlight here about the knowing the dominant eye is so important in all premium cases. See, always you should be that perfect, dead on with the dominant eye. You can play around with the non-dominant eye. See, people started talking about mix and match IOLs. So what we do in mix and match IOLs, actually the dominant eye, they put a monofocal, and the even non-dominant eye people have tried with the multifocal lens. Patients are happy. But you need to find out the exact which is the dominant eye. There are different tests to know dominant eye. If you know the dominant eye, I think your results are going to be best. Then you need not have to have a eye trace or any of the machines. Rather, if you think that, okay, the mesopic pupil size is smaller, that is around less than 3, you put them multifocal, trifocal, any ring lens, patient is not going to have a glare and halos. The problem always happens with whenever there is a larger pupil size, then patient will have a glare and halos. These are the two things I think you highlight. I think we'll have a final in conclusion in the end of the discussion.